Let me say, first of all, I'm going to give you more, probably less on Medicaid and more on some of the things that we've been doing in Massachusetts to try to contain costs and improve quality in healthcare as part of our reform efforts. If you have questions about any specifics, I will try to go through it fast to try to make up at least some of the time that we have so that we have some time for questions at the end. Anyone who has more than 4 ribbons on their badge can ask questions of me. Now, if if you have less than that, we've got Representative Marty Walsh and Representative Steve Walsh here from Massachusetts. They will answer the questions. So we'll go on that basis. The myth that keeps being perpetrated by the Wall Street Journal and a few other publications is that in 2006, when we passed health care reform in Massachusetts, that we were all about expanding coverage, and we didn't do anything about cost or quality, and that's just simply not the case, both in the initial bill as well as in a subsequent bill that we did. We established a Health Care Quality and Cost Council, which has developed a plan for moving forward on improving quality in the state and is monitoring that. We created the Connector Authority, the exchange that other states are going to be looking at, and Utah is the only other one that's done something along that line that so far that has developed that. And through that, by the Connector, as far as actually approving what's a quality health product, they are in the role of also policing the issue of improving quality and maintaining cost. And we've, by putting more people on the insurance rolls, we have been working toward reducing the emergency room use because of limitations on primary care providers, something we'll experience nationally as well. That still hasn't gone down quite where we want, but it is making some real progress. We did establish a statewide infection prevention program, which is making a difference in cost as well as quality. We funded the Betsy Lehman Center for Patient Safety, which helps us provide the academic background of the issues and works with providers to try to get them all on board of various aspects of improving the safety at healthcare providers. And also we reformed the Public Health Council to make it more based on the membership on public health professionals rather than those that happen to know the governor particularly pretty well. We reformed our boards of registration and the professional oversight boards and gave them some additional authority that I'll talk about in a minute. And we also linked hospital rate increases to the national quality standards, and we created a first-in-the-nation pediatric palliative care bill program, which has 12 different hospice and palliative care programs around the state and is certainly helping to improve the quality of care. And also in end-of-life care, it helps to maintain lower costs. In 2008, we also adopted some further aspects of health reform, one moving us to electronic health records, which are now going to be a requirement for all providers by the end of 2014. We are linking the licensure of hospitals and providers, doctors, to their meaningful use of health information technology. That is already beginning in those facilities that have begun to provide some savings, and we do have a very good study that's been verified by one of the major accounting firms as well, that even at 70% acceptance among the hospitals of computerized provider order entry systems, which is electronic prescribing, electronic test ordering, things of that nature, that we could save as much as $170 million a year for the system as well by doing that. We have also, for the pharmaceutical folks, we'd be pleased to know, we also set some guidelines for marketing of prescription drugs as to that, and that has just produced a very interesting report by the Department of Public Health indicating the millions of dollars that in some cases some physicians have been able to obtain through that process, and also through research that they do funded by the pharmaceutical providers. We prohibited payments for never events. You know, those are the things like somebody takes off the wrong arm or takes out the wrong organ or things of that nature that seems like it never should happen, and it shouldn't, but it does. We also are prohibiting, not only for the state, this is not only Medicaid, this applies to all the commercial plans as well, non-payment for readmissions to hospitals for the same purpose. And we strengthen our determination of need program to really be based on need, and in the past it had become more of just a way to collect money for the state to charge a fee, but we never really paid much attention to whether the service or the provider was really needed in the area. We have initiated a study. Actually, it's complete now. It was actually complete perhaps a couple of months ago. I think there might have been an issue with an election that might have prevented it from being fully reported prior to that, but it will be out very shortly, and it's actually a very interesting. It's not, we don't in Massachusetts create death squads, as some former governors have suggested that might be the case. We do, however, provide better education for patients and their families as to how to make the choices, and whether if somebody still wants the extreme measures, that's okay, but we want to be able to suggest that there's some better alternatives. And hospice care, there's a number of good studies that suggest that on average it extends life actually about 3 months more than the extreme measures that sometimes are, and perhaps too often, are provided. We also gave the Attorney General some authority to look at, really go into the weeds and look at what both providers and the payers, the insurers, how they build either their rates or their premiums in the process. And that had already been, one study was done last year, and other ones are coming out for this year, and that'll be an annual event. And it allows us to really drill down as to what are the cost drivers that are pushing the price of the product. We are still not only where I would like to see us, but we are working on standardizing the billing codes. One of the things that doctors particularly, and sometimes hospitals, complain about is you have to keep people that basically are almost like foreign language interpreters, because they have to understand when some particular procedure is to be paid for. Oftentimes, the different plans have different ways of coding that as to whether they're going to cover it and how much they're going to cover it for. And so we want to get that to a standardized process so that you don't have to have quite as much of an office staff just to administer the program. We have established some standardized transparency of some of these provider measures so that we can really look at long-term system reform, and one of our divisions of healthcare finance and policy is in the process of bringing that to bear. As well, in the more recent bill that we did, we have set some statutory limits on medical loss ratio. That's as many of you may know, is the proportion that is devoted of your premium that's devoted to the actual medical cost versus for administration. And that would be set at 90%, which we still think might be too low, but we're working at that, and the plans think they can meet that need. We also found that we had, with our new insurance program, particularly through the Connector Authority, the subsidized products, people would buy insurance, get a health procedure done that they knew they needed, and then drop it. So we've gone to now an annual open enrollment period, so you really have to take it at least for the year in which you're doing it, and we think that will actually save some money and improve the quality of care. We are planning in this next term, the work will be on payment reform to transition away from a fee-for-service to, Vern had talked about the global payments, the accountable care organizations, aspects of that measure, and we want to do some things. We have just released a study this past week of a successful tele-ICU run at the University of Massachusetts Medical School, actually the medical center, where they looking at having a control site monitoring a number of remote community hospitals that we can save as much as $10,000 per patient and improve quality of care. They're looking at the one site that we've established is handling now about 120 beds at remote hospitals. They have the capacity to handle 500, and it's having a full-time 24/7 intensivist watching what's going on in the ICU at the community hospital level. And an interesting statistic in the period of time they studied at 2 hospitals, there were 25,000 interventions to save the patient or to prevent them from deteriorating. Of that, about 500, I'm breaking this down a little rough, but it's within a few numbers, about 500 were interventions that the nurse on duty or the physician on duty discovered and fixed. 24,500 were discovered by the remote intensivist watching the thing and then called the nurse or the doctor to have them intervene and take action. So it has a significant improvement, and the study that was done and then verified by one of our major accounting firms, is that if all of our intensive care beds in the state were covered by that kind of a process, or at least or had full-time intensivists on site, and that's expensive for certainly for a community hospital to do, that we would save in all of our ICU beds $122 million a year and save 350 lives each year in the process, people that are caught before they deteriorate to the point that you can't really have them recover. We are also moving to doing more with telehome health. We have a pilot project going on. I think Phillips is helping us with that, to really to expand on the ability to monitor more patients and in better quality care than to have to send nurses out all the time to see them and waste a lot of time on the roads and knocking on doors. I think Vern mentioned briefly, and so I won't go into much time, but one of the key things that we see a benefit from the federal health reform is this nonprofit Patient-Centered Outcomes Research Institute. And I know a few physicians, I've seen some of the blogs, they think, well, no, the federal government's not going to tell me how to deliver health care. It's really not that intention, but when it takes, according to the federal reports, it was like 17 years for best practice to become common practice. And in one case, one of the more simple ones is hand washing. It's been 150 years, and we still see 40% of physicians not doing it routinely. So it hasn't become common practice with almost half of the physicians in the country. That's a concern. I don't think we're telling people how to deliver care in the sense of directing it from Washington or from the state capitals. We're saying, we don't want people dying because you don't want to stay current with your health care delivery. One of my pals and Governor Douglas's co-chair of the Health Information Technology activities of the National Governors Association is Phil Bredesen, and I should get a fee for this, for promoting his latest book. But I wanted to comment on a few things. I'm not going to give you the ending of his book. You have to buy it to do that. So, and what his solutions are to the problem. But these were his predictions with federal health reform. And I'll tell you what we found with our state health reform, and there is some similarities to that. He said deficits will soar. That hasn't been the case in Massachusetts. We have had some increased costs, but it's increased costs, as Vern said. Healthcare costs are increasing, and it's because of that, not because of anything we did with health reform per se. It has just really stayed within budget, and if somebody wants some objective review of that, Google the Massachusetts Taxpayers Foundation, and in their research over the last about 2 years ago put out an excellent report on what is really driving the cost, and it's not the reform effort. Costs will continue to increase. Well, again, as Brent said, they are increasing, and that's what we need to address, to begin to work on, and what we believe we are addressing. Reform makes the current problems in healthcare worse. We don't think so. We think it actually would have, if we hadn't intervened, it would have been worse than it actually is. He says he thinks employers will drop coverage. That has not happened in Massachusetts to any significant degree. In fact, of the people that now are insured, about 100,000 of them are people that were eligible for employer-sponsored coverage but hadn't taken it up, but now subsequently have, and the employers, to their credit, have honored that commitment. Now, there may be adjustments, as Vern indicated, in what plans cover, but that applies to everybody, including the ones they were already covering, not just the new ones coming in. He thinks the taxpayers will face a bailout. The CLASS program, which is a long-term care program, Senator Kennedy had been a lead sponsor of that in his time. Our program didn't particularly deal with the senior citizen part of it, our health reform initiative. So I can't really say that that's true or not. Time will tell, I suspect. State costs will increase. They haven't, other than not because of health reform. They have increased, but largely because of the economy. We have had more people largely slipping onto Medicaid eligibility, some slipping into our subsidized program, but the bulk of them, because up until this week, the Congress was continuing unemployment benefits. We didn't see any big transition to our program. If the Congress, we're hoping my former Senate colleague, Senator Brown, will have an epiphany and will vote for extension of the benefits along with some of his other colleagues, that will help us to continue to push that time off for the time being and hope the economy improves. Consolidation will increase costs. We haven't seen that happening. We don't see a lot of consolidation yet. It may. There are some pressures as we look at payment reform that could push that along toward the accountable care organization, because small individual or a couple of physicians together practices will find it harder, except by using health information technology with a virtual group, they might be able to handle it. And government will grow. In our case, it really hasn't. We have the connector authority has been maintained as a very small, I think they've got about 50 employees organization. We have probably added a few people in the insurance division and a couple of other places to help oversee that. But it has not significantly grown in our state, and in fact our number of state employees overall has been dropping. So we don't think that the predictions that Phil Bredesen has, at least as far as the state's reform, worked. He did start his political career running for the Massachusetts Senate. When he got out of college, he lost. So that might be why he doesn't understand the Massachusetts system as well as he might look at the national one. But in any event, he does have some, offers some different vision looking at it. I think he's got some good ideas. All of these ideas we continue to look at, and I think as the speakers earlier this morning talking about the constitutionality, one of the issues that there could be agreement on some changes to national health reform are that because of the way it had to be adopted, they didn't go to conference committee and didn't try to work out some of the rough edges. Those are things that I think probably a number of Democrats in the Congress and the Republicans in the Congress could agree on some adjustments. Now, they probably won't until after the presidential election, because then they lose potential points to score during the campaigns. But it could be done, and it could be for the benefit of the country. We are focusing on several things for the coming term. As I said, promoting the quality improvement and patient safety, the moving away from fee-for-service, continuing to push the implementation of health information technology in a variety of ways, and transparency, promoting healthcare workforce, because we need to continue to get more people into primary care, both as physicians and as nurse practitioners and others who can deliver that. Looking at one of the biggest issues, and we know it happens, we don't have probably as much research as we'd like to, that folks that are chronically ill oftentimes have behavioral health issues as well, and there's a link there that actually makes it worse as a result by not looking at the two together. And we also have begun an initiative to really educate patients and their families, the public in general, about how to be a good patient, how to be, if we are going to ask the physicians in the hospitals to accept risk and responsibility as part of payment reform, the patients also have a role in helping themselves either stay healthy or get better and manage their conditions. So there's a nonprofit group that's been set up, and that we need to. What I'm thinking we're going to do is require in one of our earlier bills we required the patient and family council to be established in every hospital. That has been done. There now needs to be some similarity that they're all working on the same thing of educating patients and families to be better patients and also ask better questions of their physicians and their hospitals. Just a brief mention of the CSG asked if we talk a little bit about one of the very specific tools that we've employed, particularly with our low-income population. If you look at the activities in our Department of Public Health, the folks that are earning less than $25,000 a year smoke at a rate of 24.9%, about a quarter of them do that, which is way higher than the state average of 16%. The pack-a-day smokers, and many of these are more than pack-a-day smokers, spend about $3,000 a year. That's money that could be put toward other uses, toward food or rent or something else, if we can encourage them to stop smoking. And low-income families generally have less access to the support services that are needed. By using some of the smoking cessation medications, we applied that to a 20,000, I think it was 20,000 in the group of the low-income through a Medicaid program. The interesting thing is that smoking cessation, while we kind of inferentially would understand that it will ultimately reduce the incidence of lung cancer, which will be very expensive when they do occur, the quick thing was in the first year was in cardiovascular benefits, that we saw a reduction in heart attacks and a reduction in asthma symptoms in that population. And those are both things that cost a lot of money and are high causes of premature death, as well as a reduction in claims for maternal birth complications, another area that tends to be not only expensive at the time, but expensive sometimes throughout the life of the child. So there are some significant benefits by imposing on the Medicaid population, working with them to do smoking cessation on just a couple of areas of healthcare that are very expensive aspects of healthcare. We've got several communications ways to get questions to me, even if you don't have the 4 ribbons or more, I will answer on the emails. We don't do it in person unless you have 4 or 5 ribbons. But otherwise,